And the aim of our group is to develop mathematical models and measurement techniques to enhance the diagnosis and predict outcome of medical intervention in the cardiovascular field. And I had a previous meeting with Martin, and I guess this goal, the aim of our group, is quite similar to what you aim for in your group. Maybe you have a broader scope, because I heard that people are working on the lung also. Oops. Yeah. So my personal research topics fall into two categories. One I would like to call the cardiovascular system level, and the other one is more focused on the cardiac level. So in the cardiovascular system level, we have focused on projects in the field of perinatal monitoring. So monitoring the child before birth and just after birth, and perioperative monitoring, where we studied the patient, predominantly elderly patient, who undergo major surgeries. They lose a lot of blood and then they are filled with a cardioplegic solution. And in the end, they might have gained 5 to 10 kilograms of weight because of all the fluid that has been infused into their system. So in order to do research at that level, we have models of heart and circulation combined with models of oxygen exchange and exchange of fluid in between the vascular system and the extravascular system. And we also include feedback mechanisms like the bioreflex and chemoreflex. And in this type of models, well, the role of the heart can be well represented merely by having a right input in terms of pressure and flow. That's different in the other type of models where we look at the cardiac level. And there we are really interested in the relation between the pump function of the heart as a whole and the function of the tissue at a local level. And of course, you know that we need to use finite element models over there. On top of these topics, we look at models to predict long-term effects of changes in loading of the tissue. So that's growth and remodeling. And well, we are working on steps towards patient-specific modeling. A few examples. So on the top left, you see work from Roy Kerkhoffs during his PhD quite a long time ago, as you can see. Then on the bottom left, work of Marieke Pluimert as a kind of follow-up to the work of Roy Kerkhoffs. And she looked at cardiac resynchronization therapy. And then on the right, you see models developed by Tim Hermans as a master's student a few years ago. And he studied the effect of a left ventricular assist device when it's implanted in the left ventricle. He studied how this device affects pressure and volume, but more importantly, how it affects stress and strain in the cardiac walls in the right ventricle and in the left ventricle. So in this presentation, yeah, it was a bit difficult. Well, difficult is always a challenge to make a presentation that addresses the level and interests of your audience. I talked to Martin, and he said, well, it might be quite a broad audience. So I will start at the basic level and then go more in depth. And at first, I will look at the cardiac structure-function relation. I will start with very simple two-segment models. And personally, I think that these models can give a lot of insight into what's going on when different types of muscle are pulling upon each other. And understanding this type of models can really help us in understanding the results of more complex finite element models. Yeah, I will start at the basic level. So probably all of you know this picture of the heart showing the right ventricle and the left ventricle. So this is a long axis cross-section. This short axis cross-section is maybe already less known. But what is important here is to note that the left ventricle is really the dominating structure in the heart. And it's characterized by a relatively thick wall, and it's also approximately rotationally symmetric. And because of this shape, you will see that in the remainder of my talk, we will often model the heart as a thick-walled ellipsoid. And we will focus on the left ventricle. Here you see pictures that focus more on the fiber architecture of the cardiac wall. So these are pictures made by Toran Guasp. What he did is take cow hearts and he boiled them in his kitchen at home. And then after a few hours of boiling, he could peel away layers of the heart, and he revealed this nice organized structure. If we zoom in even a bit more, then you can see this type of picture. So here you see a myocyte, an elongated cardiac cell, alongside a capillary, and you can see that these structures are connected through a dense collagen network. And finally, if you look into a myocyte, then you can see these repetitive structures called sarcomeres, and these are essentially the contractile units in the cell. Now, if you want to model cardiac mechanics, you have to quantify tissue behavior, so the constitutive properties of the tissue. And then you have to rely on experiments, and typically, this is an interesting experiment performed by Janssen and Hunter. So they took pieces of myocardial tissue and they stretched them to various amounts. And the amount of stretch here is indicated by the length of the sarcomeres after stretching. And then they stimulated the muscle. And as you can see, the muscle then starts generating force. And you can see that the level of force increases with increasing sarcomere length, or increasing stretch. And this picture shows this more clearly. Here you see the amount of stress that can be generated as a function of sarcomere length. And in fact, this local relation is the origin of the Frank-Starling mechanism that we know, and that is often used to explain phenomena at organ level. If you take the same experiment and normalize these tracings to their maximum, then you can see that the twitch, as it's called, so the duration of this active stress development, it increases with increasing sarcomere length. Another feature that has been observed in experiments is that the velocity at which the muscle can shorten depends on the level of load that it experiences. So in these experiments, well, these are isometric, so there's no shortening at all. So shortening velocity is 0, and you have a maximum active stress that can be achieved. On the other hand, if you stimulate the muscle while it's not loaded at all, it can reach a certain maximum shortening velocity. And then, well, in the regime in between, there's this relation, this hyperbolic relation between shortening velocity and load. And finally, this type of experiments also reveals the passive stretch behavior. And here you can see the passive stress as a function of sarcomere length. So if we now want to convert this information into a model, well, at first we use a uniaxial model, so that's quite straightforward, I would say. And we tend to model the tissue as a parallel arrangement of an active element and a passive element. So the active element would represent the interaction of actin and myosin in the sarcomeres, so the active stress development. And the passive element more models the effect of the collagen that connects the cells, and also the titin that gives passive properties within the cell. And well, we tend to model this in terms of the first Piola-Kirchhoff tissue stress. So actually that's the force measured in this type of experiments divided by the cross-sectional area of the muscle specimen in the unloaded situation. So this is not Cauchy stress, then you would need the actual area, but this is much more easy because you have to measure the area only once at the start of the experiment. And then this stress can be composed of a passive stress and an active stress. And the passive stress can be typically described by this type of exponential relation. And the active stress, well, we saw that the active stress depends on length, time, and velocity. So we model it as a reference level of active stress multiplied by this length dependence, a time dependence that also includes the fact that the twitch is longer when sarcomeres are longer. And then finally, we have this more or less hyperbolic relation between force and velocity. So to better understand what these properties means and how they are reflected in experiments, I want to introduce you to this experiment by Brutsaert and Sonnenblick. So this is an old experiment, as you can see, and what these investigators did was first, well, essentially the same as in the experiment that I showed you before. They took a piece of muscle, they kept it at a constant length, and they registered the force upon activation. At the other extreme, oops, here, yeah. At the other extreme, they took this piece of muscle, did not load it at all, activated it, and then you can see that this muscle will shorten and then will lengthen again. And then there are various interesting situations in between where, well, we switch from this type of contraction to this type. So this is isometric, constant length. This is isotonic, constant force, essentially about 0 on the left-hand side. And here you see a combination of the two. Maybe this one is most clearest. So what do? We have first this isometric contraction, the length is constant, and then starting at a certain force level, which we call the afterload force level, then they switch from the isometric mode to an isotonic mode. So you can see that in this isotonic mode, the force is constant, and then against this constant force, the muscle will shorten, and then it will lengthen again. And once it reaches this, let's say, preload length, then we switch again to the isometric mode. So we can replicate this type of experiment with the simple constitutive models that I showed you before. And then this is typically the result. So we have a muscle, we represent it by a parallel arrangement of a passive element and an active element. And then, well, we start this experiment by passive loading of the muscle. So it will increase in length then. And, well, essentially the force is only passive force because we did not activate the muscle yet. And then at this point, we switch to an isometric mode. We keep sarcomere length or muscle length. These are equivalent. We keep them constant. We activate the muscle, and then this red tracing shows the increase of the active stress as a function of time. And of course, the total stress increases as well. Then at some point, we reach a preset afterload level. So we switch to the isotonic contraction. The force will be constant. Also, this first pure Kirchhoff stress will be constant, and the muscle will shorten and lengthen again. And once we reach the preload length again, so this length, we will switch to the isometric mode, and then we will see the decline of the active force. Now, why is this experiment so interesting? First, it's simple. That makes it interesting because you can analyze it easily. But on the other hand, it's also quite representative of the behavior of a muscle segment in the cardiac wall during a cardiac cycle. Here we have the filling phase of the heart, so the stretching of the sarcomeres. Here we have the isometric contraction phase, so buildup of pressure while the volume of the cavity is constant. At this point then, the aortic valve would open, we get ejection, so decrease of ventricular volume, and associated with that a shortening of the fibers. And then here, well, here things go wrong in the comparison, because in the heart at this point we have a minimum volume, and if then the muscle would relax and try to increase its length, then the aortic valve would close, and this would prevent an increase in volume, and correspondingly it would prevent an increase in length. So we can modify this experiment a little bit by switching to this isometric mode at the point of lowest sarcomere length. And then you get these tracings. You can also see that the tracings are a bit shorter. That's due to the fact that, well, shorter sarcomeres have shorter twitch duration. What's interesting now is that we can plot the stress in the muscle versus the length of the muscle, or the stretch ratio, so the length divided by the length at the beginning. And then you get this type of loop. So the filling, isometric contraction, isotonic contraction, and isometric relaxation. And you might recognize this loop at the organ level, where we have a pressure volume loop. So here we have a stress stretch loop. And the meaning of the area within this loop is that it represents the amount of work generated by the tissue per unit of tissue volume. Now, this is nice. It represents already something about what's going on in a fiber sitting in the cardiac wall during cardiac cycle. But it becomes more interesting if we look at inhomogeneous situations. And these are typically situations that occur during pathologies. So what we do is we make now a serial arrangement of two muscle segments. And well, equilibrium of force now means that the stress, or the force, or the first periodic Kirchhoff stress in these two segments should be the same at every moment during this preload afterload experiment. And what I show you here is the effect of stimulating this second segment 20 milliseconds after stimulating the first segment. And as you can see here, well, the first phase, the passive loading phase, is identical for the two segments. But then this segment is activated. You see the development of active stress. But this segment, the second segment, cannot yet develop active stress. And still this condition of mechanical equilibrium should hold. So this means that the increase of active stress in the first segment should be counteracted by an increase of passive stress in this second segment. And if we look at the length of the sarcomeres, this means that, well, length of the second segment should increase in order to satisfy this equilibrium condition, and consequently the length of the first segment decreases. And as you can see, this very small delay in activation now results in quite a different time course of the length of the sarcomeres in these two segments. If we now again look at the stress strain loops, you can see that in this first segment, the blue one, we get an early shortening of this segment already during the isometric phase, whereas in the second segment, we get a lengthening during this phase. And as a result, the loop of the first segment is much more narrow than the loop of the second segment. So here you see this once again. Early segments have a low work density, and late activated segments have a much higher work density. So actually, this is caused by the temporal change in force transmission from the active to the passive tissue. So at the beginning, this late activated segment could counteract the active force in the first segment only by stretching. So this leads then to this initial shortening of the early activated segment and lengthening of the late activated segment, and a vast difference in work density. So understanding this is, I think, quite important to understand results of all kinds of simulations with finite element models, and I will try to convince you on this. So we will move on now to the finite element models, and well, first let us have a second look at the heart as a whole, the left ventricle as a whole. And essentially, these models, they compute the function of the heart and the deformation of the heart from force equilibrium, so equilibrium between forces related to the active contractions of the cells, the passive stresses that occur as a result of this contraction, and also the cavity pressure that results from this active stress development. And on top of, well, if we want to extend the model, we need to take into account geometry and fiber orientation. And here you see another set of nice pictures from an atlas produced by Anderson and Becker. And you see here that at the outer layers of the heart of the left ventricle, so the epicardial layers, fibers are more or less oriented in base to apex direction, so in longitudinal direction. In the midwall layers, it's more circumferentially oriented. And then at the inner layers, once again, we see more or less axial fibers. If we look on top of the ventricle, so here you see the left and the right ventricle, you can also see that fibers tend to cross over in between the inner layers of the heart and the outer layers. So to quantify these findings, we use two angles, and well, let me explain a bit more in detail. So let's take a point at the cardiac wall situated somewhere over here. In this point, we can define a radial direction or a transmural direction, circumferential direction, and longitudinal direction. And if we now want to quantify the orientation of the fiber, we can project the fiber vector onto the backplane here, and then the angle of this projection with a circumferential direction is called the helix angle. And we can also project this fiber vector onto the bottom plane, and then we can define the transverse angle, indicating, well, how fibers proceed from the inner wall to the outer wall. Quantifying these angles is not so easy. Here you see some measurements. These are histological measurements, and you see at this location in the wall, from the inner wall to the outer wall, you see the results of various investigations. So there's quite some variation in these findings. You can try to do better using diffusion tensor imaging. So this is work performed by my former PhD student Lisbeth Geerts. She used diffusion tensor imaging, and well, she got a similar pattern. The spread in these measurements is lower than in the histological measurements, but still there's quite some variation in the measurements. What you can see also is that, whereas here it's suggested that the inner wall is quite smooth, well, actually it isn't. And we saw that in these nice pictures that we saw before. So the inner wall, the location of the inner wall is not so very well defined. With respect to this other angle, this transverse angle, well, there is very little information in literature, but Lisbeth also quantified this angle. And here you see how this angle changes from the apex to the base, so from here to there. And this is the angle at mid-wall. There the angle is highest because at the inner and outer wall, it should be zero, otherwise the fibers would be sticking out of these inner and outer walls. So as you can see, well, it's much smaller in size, this angle, than the helix angle. And consequently, this angle is often neglected in models of cardiac mechanics. So what else do we need? Well, this was the fiber structure. We need, of course, additional information on the material properties, because now we are looking at the 3D structure. And then it's important to know that, well, the fibers that we had a look at before, actually in the cardiac wall, they are packed in layers of about 3 to 4 fibers thick. And in between these layers, the connection is more loose. So this indicates that essentially we have an orthotropic structure where we can define a fiber axis, a sheet axis, and a sheet normal axis. And you may expect then that the material behavior is orthotropic as well. So how do we define the material behavior? We model it as an elastic behavior, and hyperelastic model. That's what we use, a foam-type material. And this Q here contains the strain components in the tissue. And well, as you can see, all strain components, well, they appear in the same fashion in this Q, except for the strain component along the fiber direction, where we have this factor of 2. So this means that this material model is transversely isotropic and not orthotropic. Why do we use this model? Well, this model can quite well um, reproduce experimental data. So here you see data from summer 2015. Here you see biaxial stretch experiments. So they took a piece of tissue and stretched it along the fiber and perpendicular to the fiber by the same amount. And as you can see, with these parameter settings in our model, we can quite well reproduce the experimental findings. More interesting, no, maybe not more interesting, but more difficult experiments are experiments where we try to measure the shear behavior. In fact, Dokos was the first to present this type of experiments. And if you have a block of tissue, you can in the end define 6 different shear modes. And our model, our simple transversely isotropic model, can capture experimental data for all of these shear modes quite well, as you can see from these panels. Finally, now that we defined the geometry and the 3D material properties, well, we need to define the loading of the heart, and that we do by embedding this heart in a simple lump parameter model of the circulation, where we have the arterial system, the venous system, and the periphery modeled as a resistance. And if we combine all of this and put it in a finite element formulation, then this is typically an output that you get. So you see the change in shape of the heart during the cardiac cycle. You see the typical torsional motion that is the result of the oblique orientation of the myofibers in the wall. And you see quite realistic change of aortic pressure, left ventricular pressure, left ventricular volume, mitral valve flow, and aortic valve flow. Now this is one of the results we obtained with our models, and I want to look now in more detail at the effect of especially this fiber orientation. And in my first studies a long time ago, I assumed that this transverse angle, this crossover of fibers from inner to outer wall was absent, so at a 0 transverse angle. And at that time, I thought that the results produced by Streeter in 1969 were most reliable, so I fitted a transmural course of this helix angle to these data. I plugged it into the finite element model, and then this was the pressure volume, well, the hemodynamics, the pressure volume loop that I got. And this then was the distribution of active stress. So you see here 9 locations in the cardiac wall, and at each location you see the time course of the active stress during the cycle. And well, what can be noticed easily is that stresses in the endocardial layers are quite high, and in the midwall layers they are fairly low. And in the outer layers they are about average. So here I once again showed these results, and of course we wondered, is this realistic? And then we considered that maybe these fibers that experience a high load, well, they have to they exercise very hard, and we reasoned that they might grow, they might thicken, or they might alternatively they might die if they are overloaded. And these fibers, well, they don't have to work hard, so these fibers might shrink, the layers might shrink. So we reasoned that the inner layers might thicken and the midwall layers might thin. And if you think about the effect of thickening and thinning on the distribution of this helix angle, you can expect that if these layers thicken, that then this slope becomes more shallow. And here, if these layers thin, then the transmural slope becomes more strong. So through trial and error, we arrived at this distribution, and we plugged it into the model. And what we saw is that indeed the distribution of this active stress in the new case, so that's what I call simulation helix, this distribution is more homogeneous than in the initial case. And on top of that, also the pump function of the heart got better. We also looked at other aspects. So we took the same 9 nodes and then we looked at the amount of rotation of these nodes about the long axis of the ventricle during the cycle. And then you can see that we have quite strong variation of the angle of rotation going from the inner wall to the outer wall. And in fact, this gradient is much stronger than observed in experiments. So we wondered what is causing this. And to explain this, we can make use of a very simple conceptual model. So this model focuses on the subendocardial layers of the left ventricle and the subepicardial layers. So you see them indicated in red and blue. In the subendocardial layers, fibers are oriented like this. And in the subepicardial layers, they are oriented well, in quite a different angle. If we now would activate these fibers, they would tend to shorten. And this would mean that the inner layers, if we keep the bottom or the top plate fixed, the inner layers would move like this, and the outer layers would move like this. So you have a difference in twist of the inner and outer layers. And if we then observe this from the apical view, this is what you get: counterclockwise rotation of the inner layers, counterclockwise rotation of the outer layers. And this then causes this strong variation of rotation angle from inner to outer wall. If we now take into account this endo to epi component of the myofiber path, so this transverse angle, then well, this fiber, if we let it shorten, if we activate it, actually it would counteract this motion, and the combined effect would be that the differences in rotation between inner and outer wall would be much reduced. In fact, this can be interpreted such that in this case, the shear force that the active fibers exert on the myocardial wall, in this case, it has to be counteracted by the passive tissue alone. But when we include this transmural component, then it's also the active tissue that assists in transmission of the shear force. So what did we do? We took the model that we had before with the blue course of the helix angle, and we added to that a non-zero transverse angle. And well, the actual transmural course was determined in a series of studies. If we now look at the results of this model, first we see that pump function is increased quite considerably, and we also see that the rotation of about the long axis, especially the transmural gradients, they are much reduced. And well, active stress is modified a little bit. So to summarize, we saw 3 models, identical except for the distribution of the myofiber orientation. We see quite a strong shift in performance of these models. And the explanation, in fact, can be best explained from this type of plots. Once again, we see stress strain plots. Now you see average stress strain plots, average over all the black nodes that you see over here. And well, what is the main difference between the last simulation and the previous simulations? That is that during the isovolumic contraction phase, myofibers tend to be, well, to maintain their length. There's very little shortening during the isovolumic contraction phase and the initial phase of ejection. So this means that fibers are on average longer during this phase, and then thanks to the dependence of active stress on sarcomere length, they are more powerful and hence they can generate more pressure and more stroke volume. So you might wonder, okay, that's a nice story, but it's all modeling. Is this actually true? Does this hold for the real heart? And we try to test our findings by looking at strains measured in the heart using MR tagging protocol. So what we did is we measured in several volunteers this type of deformation patterns at 3 levels in the heart, in a level that I call the basal level, the mid-wall level, and the apical level. And so we analyzed these movies at these 3 different levels, and we determined the average circumferential strain in these slices and the average circumferential radial shear strain. And this is what we found. So here you see a typical result of an experiment. It's a circumferential strain during the cycle. And you can see that at all these 3 levels, the circumferential strain is essentially the same. And we also found this in our models. So the model helix, where we had no transverse angle, and model ref, where we had a non-zero transverse angle. So the details of the fiber structure do not matter too much for the circumferential strain patterns. This is different if we look at circumferential radial shear strain. In the experiment, we saw a common decline of the shear strain during the first part of the injection phase, and then the patterns diverged. You can see at the base, shear strain starts to increase, whereas at the apex, the shear strain, well, decreases further. In the model helix, so without the transverse angle, we found this pattern. And the first thing to observe is that the amplitude of the shear strain is much larger than observed in the experiment. So essentially this gray zone denotes the range of strains in the experiment. So you can see the range is much larger. And also the base to apex trend is different. Here we saw lowest strains at the apex, whereas in the model we see the highest strains at the apex. Now in this reference model, where we did include this transverse angle, there you see that the patterns are more similar. Still here, the pattern is a bit stronger than here, the amplitudes are stronger, but the longitudinal variation of the strains is much more similar than to that observed in the experiment. So this strengthens the idea that this transverse angle is an important component that should be included in this type of models. So what can we do with the models? We can simulate pathologies, for example, left bundle branch block, and this is characterized by a strong variation in activation time throughout the left ventricle. So we did a simulation. Here you see in blue the reference simulation, and in red the pressure volume loop for the left bundle branch block. And here you see stress strain loops taken at several locations in the wall. And what is to be noted is that in this early activated region, the stress strain loop actually is traversed counterclockwise. Normally we go, as you can see over here, we have the filling, isovolume contraction, ejection, relaxation, but here we have early shortening of these early activated fibers, and in fact, the loop is traversed in the opposite way, opposite to what we see normally. To explain this, well, this can be explained, of course, from what we saw before in this very simple 2-segment model, where we also saw how active work density depended on moment of activation. Another thing you can simulate is acute myocardial infarction. We simulated it by preventing active stress development in this region. You can see that it has a more dramatic impact on the pressure volume loop. And you can also see once again take a look at the stress strain loops. And now it's interesting, for example, to look at this location anterior medial, that's this location. And here you see that fibers shorten more during the isovolumic contraction phase than normal. Blue is normal and red is in the infarct case. And this can again be explained from the fact that these fibers located over here, they pull upon the passive fibers in the infarct region, so they can stretch, they can shorten more easily, and since they are shorter, they can also develop less active stress. That's in contrast to the situation over here in the lateral region. Here the fibers are in parallel to those in the infarcted region, so they are stretched along with these passive fibers, because, well, the infarct region, it bulges out, it's stretched. I did not point that out, but here you can see there's no active stress and there's a lot of stretching going on in this infarct region. But these fibers that are perfectly healthy, they still are stretched along with the fibers in the infarct region. So they become longer and consequently they can develop more stress. But again, especially this effect can be explained from, well, the simple analysis with our two-segment model. What about the time? Do I have time to say a little bit about patient-specific modeling?
Yeah, 5 minutes more, something like that.
Okay,
Thank you.
I will manage it. So if we now want to convert these generic models to patient-specific models, well, of course, we have to have patient-specific parameter settings, and some parameters we can observe directly, but most of them we will have to obtain from an inverse analysis. And part of this inverse analysis is a sensitivity analysis. So it's important to know which aspects of the model input are important for the model output. So we have to define model output. We will look at strain fields because they contain a lot of information on the state of the heart. And we are interested in, well, which parameters are influential for the strain field. And this in fact work performed by Luca Barbarotta. He completed his PhD early this year. And he looked at sensitivity of strains to geometry and fiber orientation. It's important in this type of analysis that you have a realistic range of the input parameters. So concerning shape, we took data from a study by Fonseca. They analyzed 300 healthy volunteers. They analyzed the shapes of their hearts, and they summarized their findings in terms of let's say, an average geometry and typical shape modes. So these are typically the ways in which individual hearts tend to diverge from the average heart in the population. And what Luca in the end did is create 1,000 models with different shapes, and the shapes were defined by variations according to these shape modes, and he varied the geometries over plus or minus 1 standard deviation. Luca also looked at sensitivity to fiber orientation. He had a simplified description of the fiber field, so a 3-parameter description for the helix angle and a 2-parameter description for the transverse angle. And the 5 parameters in this model, they were varied according to observations, experimental observations published in literature. So these are typically the variations in these 5 input parameters. So he created 2,000 models where both geometry and the fiber field were varied. And for each model and for every node, he computed the 6 cardiac strain components. These components were measured at end ejection with respect to begin ejection. So it's a strain going on in between those 2 time points. And he determined the strain with respect to a wall-bound coordinate system. So then per node and per strain component, he computed the coefficient of variation. So he took all the strain components and he averaged them and took the standard deviation. And then he defined the coefficient of variation as a standard deviation over the mean. And finally, he averaged all these coefficients of variations once again to determine, he averaged them to determine the average and the standard deviation. And this is typically what he got. The variations in geometry on average gave a coefficient of variation of about 10%. And the shear strains were affected a bit more than the normal strains. Looking at the fiber field, the variation in the fiber field, you can see that the variation due to these realistic variations in fibers, fiber orientation, well, they yielded a much stronger variation of the strain components, and especially the circumferential transmural shear strain component was much affected by variation in the fiber field. And from this, it was concluded that, well, if you want to come up with realistic patient-specific models of cardiac mechanics, well, you have to pay great attention to accurately modeling the fiber field. Now that's easier said than done because we saw that measurements give a lot of show a lot of variation in fiber field, and that's the last. I have 2 slides left, I think, because it's so difficult to accurately measure fiber orientation even in dead hearts, let alone in living hearts of patients. We came up with this hypothesis put forward by my PhD student Wilco Kroon some 10 years ago. So essentially reasoning is as follows. Here you have a piece of passive tissue. You see in dark red the myofibers and cross-hatched the connective tissue. Now, if we activate the fibers, they tend to straighten, they tend to deform the passive tissue, and also the tissue as a whole might rotate. But if we correct for the rotation, then we might see that, well, there is a shear deformation imposed on the passive matrix, and we reasoned that this might damage the matrix, but also knowing that the matrix adapts or remodels on a time scale of about 1 month, we thought that in the end, the orientation in the active tissue might be frozen into the passive tissue. So the effect of this whole process is that the orientation of the fibers in the active state starts resembling more and more, or no, is frozen into the orientation in the passive state. And we model this with a simple evolution law that says that the orientation of the fibers in this passive state approaches the orientation in the active state. And my PhD student Marieke Pluimert, well, she implemented this model, and well, here you see in this left ventricle the initial orientation of the fibers, this helix angle distribution, no transverse angle, and in a series of adaptation cycles, she computed the evolving fiber orientation. And as you can see, well, at first the helix angle distribution doesn't change too much, but we get the typical distribution of the transverse angle that we saw earlier, and that's also observed in experiments. If we continue this process, well, finally it diverges. So this is not the whole story, but well, it gives us an idea on how to define the fiber field in patient-specific models. Once again, if we now look at what the effect of this reorientation is, well, this is the initial pressure volume loop, and in black we see the pressure volume loop after adaptation. And here we see average stress strain loops, and that's a picture we saw before. Due to this formation of this transverse angle, we get much less a shortening of the fibers during either volume contraction, and this explains then the increase of pump function in the adapted heart. And that's about it. This is, well, a summary of what we have seen. Fiber orientation is important, and well, transmission of active force through active elements, that seems to be a design rule for the normal heart, because then we get best pump function and best matching of experimentally observed deformation. It's important to choose patient-specific fiber orientation well, and we might use remodeling algorithms to determine this. And finally, and maybe I did not stress that too much, but we have seen that precious volumes and circumferential strains are not very much affected by the choice of fiber orientation, but shear strains are. And if we want to create realistic models of the complete shear in the cardiac walls, well, we need to validate those models on shear strain also. And well, I have a list of people I have worked with, and well, they contributed to the material that I presented to you today. Thank you.